much simpler than the clinical side, so it will be a shorter lecture, and let's see how we get along. Now, in the beginning, right in the beginning, can you hear me? Yes. It is worth differentiating what's a diabetic kidney disease and what is diabetic nephropathy. So what's a diabetic kidney disease and what is diabetic nephropathy? Diabetic kidney disease is a clinical term, clinical suspicion or clinical diagnosis of renal involvement in diabetes mellitus, and nephropathy is at the tissue level. Means the renal biopsy shows there is renal involvement. So the pathology is involved at this point. Right. So now, when does the clinician usually perform a biopsy? With renal manifestation. There is some variation here, which Dr. Lavedi told us, that absence of diabetic retinopathy is not a uniform one. It differs from between type 1 and type 2. In general, if it is diabetic retinopathy is absent, biopsy may not be performed. If diabetes is of short duration, or diabetes presenting as a nephrotic syndrome, then it becomes as a presentation with short duration of diabetes, then clinician may wonder whether it is the proteinuria is due to diabetes or due to something else, may do a biopsy. If urine analysis shows a sudden onset of macroalbuminuria, sudden onset, or active urinary sediment or hematuria suddenly, then another pathology may be suspected. If there's acute renal failure, rapid rise in creatinine or decline, acute decline in GFR, eGFR, or clinical suspicion is of definite non-diabetic renal disease. For example, glomerulonephritis, vasculitis, or amyloid, etc. is suspected. Or the lab tests, laboratory tests indicate non-diabetic system. Low complement, autoimmune screen comes positive, virology screen positive, serum protein electrophoresis in an elderly patient shows N components, then a biopsy may be performed. So all these things we have to keep in mind, the pathologist. Because if the biopsy is done in a diabetic, the clinician is not necessarily looking for diabetic changes only, looking for diabetic nephropathy being present, but also he or she is trying to find out if there is dual pathology, something else apart from diabetes, or it is not diabetic nephropathy at all, but some other disease causing. So we have to remember, rule out non-diabetic causes of pathological lesions in a biopsy from a diabetic. Now, what are the usual lesions in diabetic nephropathy? In the glomeruli, you see excess of mesangial matrix, but that's a very non-specific lesion. In many diseases, kidney diseases, excess in mesangial matrix. Fibrin caps, again non-specific, but they are more marked, more eye-catching in diabetic nephropathy. Capsular drop is more or less specific for diabetes, but any cause which leads to leakage of plasma protein can cause plasma protein, any etiology. But more or less, you see usually in a setting of diabetic nephropathy. Nodular glomerulosclerosis is the hallmark lesion, Wilson lesion, which is supposed to be a hallmark of diabetic nephropathy, but as I will show you later, it can be seen in a few other conditions as well. You get arteriolosclerosis of both afferent and efferent artery. You see only afferent arteriolosclerosis that can be a part of hypertensive, and often it is combined with diabetes. Papillary necrosis, not usually seen in biopsy, but can be picked up sometimes. Thickened glomerular basement membrane that needs electron microscopy. An Epstein lesion of tubules, which is not very often reported. We will see an example of it, which how the tubules look in this lesion. Right. So there was such a variation in reporting of diabetic nephropathy that in 2009, a year before this publication came in the Belgian town of Leiden, they classified the pathology of diabetic nephropathy. And So the 5 different classes were designated. The reason was to promote uniformity of reporting, to lay down a baseline for future clinical trials, and also the progress of diabetic nephropathy and the different managements and so on, and the incidence of diabetes in different countries at different ages. So class 1 is the mildest form. You see mild non-specific changes only, and the lesion you have to look for is a thickened GBM on electron microscopy. The GBM measurement on electron microscopy differ from lab to lab, but in general, in males it should be more than 430 nanometers. In adult males, in adult females, it should be more than 395 nanometers. Above that level, it is usually called class 1 diabetic nephropathy. And obviously, no other lesion should be present. No other lesion should be apart from it. That's the only lesion present, then it's class 1. And so it's missing there. It should say no other lesion present. Class 2A, we are going now into the area of mesangial expansion. If it is mild mesangial expansion affecting less than 25% of the glomerulus in the worst affected glomeruli, no other lesions are present, then it is class 2A. Class 2B is more than 25% of mesangium, no other lesion present. That is severe mesangial expansion. So then that's one grade higher. Then number 3 is a classical lesion of nodular glomerulosclerosis, Kim-Stahl-Wilson lesion. Even one, at least one, but even one lesion is enough. And the requisite is that class 4 should be absent. More advanced sclerosis should not be there. And class 4 is advanced diabetic glomerulosclerosis. More than 50% of glomeruli are globally sclerosed. But because this change can be non-specific, glomerulosclerosis itself, in order to it to be called diabetic advanced glomerulosclerosis class 4, you must have class 1 to 3 present. Then you can be sure that the glomerulosclerosis is because of diabetic nephropathy. So this was the classification which was laid down in 2010, published. Right, so this is class 1 lesion on EM performed here. You see the measurement here is in micrometers, 1.676, that translates to 1676 nanometers, almost more than 3 times, nearly 4 times the upper reference range, limit of reference range. So that is definitely type 1 Leiden class of diabetic. So, but if other lesions are present, then you can't call it class 1. If more advanced lesions are present, then it goes to the designation goes to class 2, 3, or 4. Then class 2A is less than 25% of the glomerular mesangium is sclerosed. 2A is mild. Class 2B, more than 25% of mesangium is sclerosed. And class 3 is nodular glomerular sclerosis, so-called Kim-Stahl-Wilson lesion, provided class 4 is not seen. So there is no sense of glomerular sclerosis, over 50% of glomeruli being involved. If that's not present, and only this lesion is present, it will be called class 3 or Kim-Stahl-Wilson. And this is an example of class 4. You see nearly all the glomeruli I've seen, about 8 glomeruli I've seen here, all of them are globally sclerosed. So this is almost end-stage diabetic nephropathy, class 4. And in this particular biopsy, it also had areas of KWS. And what about the other lesion? This is the fibrin cap lesion here. Bright red is staining in PAS stain. It is, as I said, very eye-catching, very prominent, but it can be seen in any cause of severe proteinuria, basement membrane damage. That's the capsular drop right there. More or less specific for diabetes, but rarely can be seen in other pathologies as well. And that's the hyaline arteriolosclerosis. both arterioles are not seen, efferent and efferent arterioles are not always seen in the same section. But because this patient had capsular drop and this, so we can safely say this is diabetic arteriolosclerosis. And that's the lesion known as Epstein lesion, sometimes known as Armani-Epstein lesion, and extreme tubular vacuolization, supposedly because of long periods of severe hyperglycemia, uncontrolled. It's very uncommonly seen nowadays. And this is kidney, which shows papillary necrosis, 1, 2, 3 papillary necrotic. Apart from diabetes, is seen in analgesic nephropathy and some hematological conditions as well. And basically, it is because of microvascular disease which causes ischemia of the papillae. It can sometimes be seen in severe pyelonephritis associated with this. Biopsies, I've seen only one case, needle biopsy diagnosis, which is this one here. That's the viable but congested cortex, and that is starting of medulla, which is completely necrotic. So it can be picked up in biopsy, but it's quite unusual. Sometimes the necrotic papillae, they detach, and they can cause ureteric obstruction. They may present as ureteric obstruction and hydronephrosis, acute hydronephrosis. What about other pathologies seen in diabetic nephropathy itself? And one is collapsing. It keeps on appearing, collapsing morphology, in many different types of glomerular pathology. Saw it in IgA nephropathy, in lupus also it is seen, and then of course HIV and drug abuse cases, parvovirus B19 infection. So if you see collapsing glomerular nephropathy, in collapsing morphology in diabetic nephropathy, not commonly seen, then usually it's associated with sudden onset of severe proteinuria. Then another condition is IgA positive, acute post-infection. Usually the infection is Staphylococcus glomerulonephritis, and it shows humps, as you would find in the sort of post-streptococcal acute diffuse proliferative GN, very similar to it. Usually a history of respiratory tract or other infection, usually non-respiratory infection more commonly, and staphylococcal septicemia. Now, when you look at the series of cases in which renal biopsies are done in diabetic kidney disease, there is a problem. And the problem, as was well shown by Dr. Vaidi, is that threshold for biopsy varies. Different centers will do or not do biopsy in a case, kidney disease, depending on the cost and attitude of the nephrologist. Threshold is fairly low in North America and Europe, especially UK is even lower because the biopsy is free on NHS. You don't have to go through insurance, so it's more commonly done. But they still have some sort of threshold there to do biopsy. Because of this, you can't know actual incidence, true incidence of diabetic nephropathy in diabetic kidney disease. True incidence is difficult to assess. Secondly, the duration diabetes. This is more precise in type 1 diabetes than type 2 diabetes. So it's difficult to say when does diabetic nephropathy appears in the course of diabetes. Difficult to say accurately because of these two reasons, threshold of biopsy, and also some people may wait for longer time. So it's a selective population, and also duration we are not sure. Now this is a US large series, came out last year, Nature Reviews, histological finding diabetic patient. And as I said in my earlier slide, 37% of them will have pure diabetic nephropathy. So these cases have to be looked at carefully by the pathologist, rule out other pathologies very carefully to be sure that there is nothing else involved except diabetes. 36%, about equal number, had dual pathology. So there's diabetic nephropathy and some other pathology superimposed on it. So here the nephrologist was correct in doing the biopsy. Picked up another pathology, treatable or not treatable. and a smaller percentage was of non-diabetic pathology. Again, the renal physicians were corrected doing the biopsy because totally unrelated pathology, not related to diabetes, was discovered on biopsy. I'll show you a few examples seen here in Bahrain, Bahrain practice of dual pathology in diabetics. This was a female, 38 years old, type 1 diabetic for 11 years with proteinuria, 1 week history of pneumonia, acute renal failure. And you clearly have nodular glomerulosis in this patient, excess mesangial matrix as well. But if you see carefully, there are quite a few cells, inflammatory. You shouldn't see a lot of inflammatory cells in diabetic nephropathy within the glomerulus. Not a bit, in fact, necrosis as well. Necrosis. There's no crescent in this particular field, but that should raise your suspicion. So this should be a bland lesion. It's bland here, but then the rest of the lobules are infiltrated. Then both IgG and T3 linear staining. Now, the problem with linear staining, I showed you in my first lecture presentation, anti-GBM disease. This is fairly smooth and continuous staining. But in diabetes, you have already another pathology underlying it. So you will not find a linear profile which is continuous. You'll find sort of broken profile because part of the glomerular capillaries loops are abnormal. But you have a big KWS lesion here, linear positive, T3, and also IgG. And it turned out to be positive, anti-GBM. Practice here is that anti-GBM results are known at least 2 weeks later, so you can't wait for that long. So biopsy diagnosis is very important. GBM disease positive. Because clinically it can be suspected as. This was KWS in anti-GBM. This was another case of KWS. The beginning of KWS here, the mesangial increase. But again, male of 45, type 2 diabetic for 11 years, proteinuria, but recent hematuria and 1 year's history in hypertension. And you see a small crescent. Again, cells, inflammatory cells. Endocapillary hypercellularity, blocking the capillary lumen completely. Beginning of a KWS node here, and it's IgA positive. Now here you notice the IgA is present in the mesangium also, but in the capillary wall broken. It's sort of one of the aggressive type of IgA, but superimposed on diabetes. Third case is again a female, 45 years old, type 2 diabetes for more than 10 years. The proteinuria, had proteinuria and had 2 weeks history of hematuria, rise in creatinine, active urine sediments, no clear history of upper respiratory tract infection. And again, you have KWS. This is a silver stain and lot of cells within the capillaries, many polymorphs amongst them, many polymorphs. And this is a case from Guy's Hospital, so immunoperoxidase. Immunoperoxidase showed C3 staining in the quite lumpy as well as granular in the capillary walls, also in the mesangium, and humps, subepithelial humps. So this was acute post-infectious GN in a diabetic. The key feature of all of these is that if you find in a diabetic nephropathy is a lot of inflammatory infiltration, then that is something else. So it should be fairly easy to pick up. And of course, confirmed by presence of immune deposits and also electron microscopy. Now, case for male 50, Type 2 diabetic, 15 years, increasing proteinuria over last 12 months, gradual rise in creatinine. This was a difficult one. He had 2A, the sort of less than 25% of the glomerulus had increased metrics. But you also had glomerulomegaly. In a digital setup, you can directly measure the glomerular diameter. So there's a measuring sort of application present. So this was 342 in excess of micrometers. It should be less than 220. So it's definite increase in diameter, glomerulomegaly. Also, fibrin caps are there, but there's an area of adhesion, capsular adhesion with. Now, this is not due to diabetic nephropathy itself, but that doesn't cause adhesion. Another one here. So this is FSGS. The history goes with it. It fits with the history with nephropathy of 2. Now, whether this is a primary or secondary one, this particular case, it was difficult. Most likely primary because tissue damage, background tissue damage was not extensive. It could have been most likely primary, and there is also glomerulomegaly. But it can be very difficult to diagnose FSGS in a case of diabetic nephropathy. Another difficult area is thin membrane disease in diabetes. It does occur, but our existing way of measuring thin membrane will not always work because, diabetic, by definition, diabetics have thickened TBM in most areas. There will be areas of segments of basal membrane which will be thin, difficult diagnosis. Now, this was another case of a female of 39, sudden rise in serum creatinine proteinuria. I think she was type 2 diabetic, mentioned it there. Typical lesion of 2B. There is an increase in mesangial matrix, also collapsing. Diabetic vasculopathy. So typical collapse with podocyte hyperplasia. You had a creatinine rise as well as proteinuria. This case was a male of 59 with diabetic for more than 30 years, infected foot, and as a creatinine jumped 3 times in 2 weeks after treatment. Vancomycin, that itself was a giveaway. Had KWS, but had severe acute tubular injury. You can't recognize. Most of them are in fact proximal tubular, so dilated. In fact, there is some desquamation of tubular epithelial cell into the lumen, severe acute tubular injury, most likely due to sin. What are the other possibilities seen, other pathologies? You can see lupus nephritis, thrombotic microangiopathy of various causes. You can have accelerated hypertensive disease, membranous GN, or thin membrane disease. So it's not the end, believe me. Right. Now, there are other renal diseases which may look like diabetes. So if you have the nodular, typical nodular mesangial expansion, it can be amyloid, easy to pick up. Most pathologists can pick up amyloid, even on H&E. It's best to confirm it with Congo red stain and other stains, and by EM. Heal MCGN. MCGN has a lobulated profile. When it heals, it can have central sclerosis, then can produce nodules, but it will still have some positivity for C3 and other immunoglobulins. This condition is not common, idiopathic nodular glomerulosclerosis, associated with hypertension and smokers, chronic heavy smokers. Looks exactly like diabetic glomerulus, exactly like nodular glomerulosclerosis, KWS, except that there may not be any history of diabetes. and light chain deposition disease. If there is diffuse mesangial expansion, class 2A and B lesion of Leiden classification, could be IG nephropathy. It should be easy to pick up in a decent lab at immunohistology. Fibrillary nephropathy is an uncommon condition, which is huge.